Hi, good evening. I'm Dr. Philip McMillan. Thank you for joining me as I take on this interesting topic about the amount of lives saved by the COVID vaccine across Europe. Interestingly, this was something I discussed in January of this year. And this was related to the WHO doing a link to the fact that this paper was coming out. So the paper was in the preprint stages in early parts of the year. It was only just published. But at that time, my question was, how do you explain Africa? That seemed to resonate with people because we ended up with almost 450,000 views of that video. And so look out for that on the channel, and I'll make sure there's a link for it at the end. But it raised a question because to me, the numbers didn't make sense. And it's not that there was no prevention of deaths from COVID 19, but my simple analysis is this: if we had increased deaths prior to the vaccine related to the pandemic, which we did, what you would expect is that if the vaccines have therefore prevented more COVID deaths, you should see a significant drop in mortality, simply because the people who were going to die had died. And so they wouldn't die again. And so what you would expect is a significant drop in mortality, kind of like what we saw with, say, Bulgaria, where it went down about 10 to 15%. Now, they were very low vaccinated, so they had a big surge with COVID infection and death. But then after it passed and the country got to herd immunity, the levels would have dropped well below the normal. That's what you expect. That's not what we saw across Europe, because if you remember Andrew Bridgen raising the question in the UK about the excess deaths still being up all the way into 2023, so much so that they had to change the formulation of the analysis of excess deaths to try and say, well, there is no issue. The reality is that excess deaths, even if they are normal at this point, is still elevated. It should easily be 10 to 15% below what we would expect because so many people have died. So, before we get into this a little bit more, because I'll explain the science around this, my thought on it, and critically, where the paper I think underestimated or overestimated the benefits by not understanding exactly how the disease operates. Additionally, I will play a short clip from a most important interview with Professor Christine Stabell Benn from Denmark, where we were talking about the low risk cohorts and whether or not they should have been vaccinated. So, this is all to come, but just remember that there will be a link in the description below for you to get the free ebook on nitric oxide. And this is about protecting the upper airways, especially the sinuses, against COVID infection. Actually, it works for all viral infections and bacteria as well. So please make sure you get that and subscribe to our newsletter. Make sure you click on the link, and there should be a bell here to subscribe. And also, when you subscribe, make sure you click on notifications so you see when these videos are going live. So, critically, let's get back here to this scientific question. And it was this paper that came out just recently that caught my attention. I don't know if this is big enough for you to see, but essentially, this here was talking about the estimated number of lives directly saved by COVID vaccination in the WHO European region between December 2020 to March 2023. And this was a retrospective surveillance study. It was fully published in the Lancet here, August 7th, 2024. So if you remember, as I said, I spoke about this paper in January of 2024, and this indicates that they waited for it to get in the Lancet top level publication because they thought it was that important. So the question is, what really are the risks with regards to COVID 19? And this is why I encourage people to learn about the science around it, because the virus, it's not over. And so the more you understand, the better you are. And part of what I've been focused on is this storm, spike triggered autoimmune response mechanism, which I am predicting is the next phase of how this epidemic in highly vaccinated regions is going to evolve. And there are links in the description if you want to join that course and get some more education on it. But I have here a post that I did. This is on my Substack. And it was all the way down in 2022, in January 2022. And I was asking a simple question: why don't all unvaccinated people with COVID end up in ICU? And I was explaining that you had to understand how the disease operated. You had people with comorbidities, and you had people who were unvaccinated with COVID. And what I was highlighting here is that where you had an overlap, where people with comorbidities who were unvaccinated, that's where you had a higher risk for ICU. But it's more complicated than that. Because in this cohort, if you think about it, you know many people who are unvaccinated and with comorbidities and didn't end up on ICU. The question is, why didn't everybody in this cohort here end up on intensive care? The reason is about the science. And this is why I'm saying is when you understand the science, everything else starts to make sense. And so just explaining an important thing. This virus is exceptionally good at hiding from the immune system. It's what we call the fact that it can mask interferon. Interferon is the warning signal. It's like a ninja hidden in the dark. But the funny thing about it is that it doesn't have any extra weapons other than the fact that it has stealth. So it's kind of like the invisible man. If you spray paint him where he can no longer be invisible, he doesn't have any other weapons as such. And so the virus is similar to that. So when the immune system even partially recognizes just the shape of it, there will be an interferon response and the virus will immediately not be so effective. And that's the basic premise that we have to go from here. And I'll show you again, this is where the evidence was shown as one of my most important slides about the interferon response in terms of disease severity. And it was done in 2016 with SARS-CoV, and the principle applies with SARS-CoV-2. And the principle is simple. If your immune system had any recognition of any coronavirus or even a rhinovirus, it would have an early interferon response. What it means is that the virus can't hide and the spread to the lungs before the interferon is signaled. Once interferon is signaled, everything kicks in. You have some inflammation in the lungs or, a few symptoms, and that's it. Mild disease. Similarly, or more interestingly, is the fact that in people who were older, and think about this, you probably know lots of older people with lots of comorbidities who got COVID and didn't die. And one of the reasons for that, if they didn't have this point about early interferon, the other thing is that if they had a weak interferon response, I'll show you here, a weak interferon response would not cause severe disease. Really important. Where you had severe disease, a very dysregulated monocyte response with immune pathology and lethal pneumonia, was if you had a strong interferon response that was delayed. Look at the time difference. This is early, this is late. So you have a strong interferon response that's delayed, then you have risks for severe COVID-19. So when you think about that, and you think again back to what I was describing in that post that I did about why didn't the unvaccinated all die, and the reason is very simple. I'll try and see if this is a little clearer for you, is that in effect, for the people even with comorbidities, the percentage of them who had no exposure to any rhinovirus or coronavirus in the recent past was actually quite small. It would be down here, just as a piece of this. And it is this group of people who didn't have that, or they had interferon autoantibodies. That's the other big factor where it blocks the interferon response. They are at risk for severe disease. And so when you look at that and you realize that when you think about what happened with the rollout of vaccines, the more people who were exposed, the less their risk. Really important. And I don't think they took that into consideration in terms of the study. And so you can't see the full study because it's behind a paywall, but I happen to have the preprint here, which is still available to look at. And as you can see, in terms of who was involved, WHO, let me just show you all the affiliations here. So the WHO, the Medical and the Public Health Services in Cyprus, National Institute of Public Health in Prague. And so all of these people, I think, have a vested interest in the fact that they need to show that what they have done was correct. And it's not that they were incorrect in terms of their initial thinking. I just think that they went way beyond what was appropriate in terms of the risk factors for people. So, in order to grasp what I'm saying there with that, I want you to listen to a piece of the conversation when myself and Professor Stabell Benn spoke about the fact that there was a vaccination of the low risk cohorts. That means the groups that had low risk of any severe disease. Listen to what she had to say here and make up your own mind. What was the logic, do you think, of vaccinating the low risk cohorts?
Well, we know the arguments that were put forward, but I was all the time arguing that we couldn't we couldn't justify vaccinating the low risk cohorts from the perspective that we didn't know the full story about the vaccines. They were new platforms for delivering vaccines. They had only been tested in a few months, and we had no way of knowing what would be their overall health effect. And of course, coming from my perspective, this was the important question. We had seen that other vaccines could have non-specific effects that could be even more important for overall health than the specific effects, and that could sometimes be negative. So for a healthy young adult with no comorbidities, the risk of severe COVID-19 was literally zero, and therefore any side effect, any negative non-specific effects would have made the equation look really poor for that individual. And this was why I was all the time arguing that there was no justification for vaccinating younger healthy adults, and particularly not children, and definitely not for mandating it.
And so, what kind of, because you would have been one of those voices that they wouldn't have liked saying that because you're high standing in the industry. What kind of pushback did you have, even personally or professionally, when you started to do that?
Well, it was very easy during that time to be tagged as an anti-vax, which is absolutely ridiculous. I've been working on vaccines for decades. I've been promoting particularly those live vaccines. I'm full of scars from the BCG vaccine because I take it ever so often. I'm pretty convinced this is a key to good health because of its immunostimulating effects. But this tag was used so much in the public debate about vaccines, and it became an excuse for dismissing people. It was a tag that you could put on people and then you could stop listening to them. I experienced that quite a lot despite my track record. And I know it was even worse for other people during that period, which was really nonsensical and terribly dangerous to shut down the discussion about vaccine safety in a period of rollout of a new vaccine.
I can't explain how important that interview is, and the link is in the description. So you can go and look on Substack for the full interview. That interview is probably going to be one of the most important interviews that I've had similar to a kind of GERT interview when I had the initial GERT interview, because of how balanced she is, talking about the risks, the benefits, her background in terms of vaccine industry, listening to where she's come from, what the challenges were with non-specific effects of vaccines. And so it's a very important voice. I'd encourage everyone to listen to that video. Really important information in there. But she highlighted again another part of the difficulty when they came to estimating about all of these deaths that were there. I've highlighted something from the paper again, and I'll show you this here. Um, it was done in the European region in the period of December 20 to April 2023. And the estimated COVID vaccination programs were associated with a 57% reduction in the number of deaths among those greater than 25 years old. And that represented 1.5 million lives with a range of zero point 0.7 to 2.6. This bit here, the over 60s age group accounted for 96% of the total lives saved. So, what they're highlighting there is, just as I said, in the low risk cohort, they were really at low risk, except if they had interferon autoantibodies. And to be, well, I'll come back to early treatment in a minute, but the majority were over 60 years old, and even over 80 years old. That was 50% of the cohort who were, in their minds, lives were saved. So I'm one of those people who never had an issue with the fact that they could and should have vaccinated the high risk cohort when we didn't fully understand all of the ramifications of the disease. It made perfect sense. But to roll it to the low risk cohort, when you don't understand what the benefits and the risks are, to my mind, made no sense. And that's what I'm looking for with regards to excess deaths. One of the important things that comes out is that when they are looking at these studies, they are only interested in whether or not people died from COVID. But what if it put them at risk for other conditions? Because how else can you explain, as I said, if people are protected by having the infection, and those people who survived the infection didn't have severe disease would have been even more protected, they weren't at very low risk of death. And so when you think about the equation with regards to risk and benefit, that would be continually falling down. I'm going to show you a slide here that, and this is my work. So if a statistician looks at it, they may decide that my analysis here is not quite right. But just take a look at these numbers that I have put together with regards to the original data. And so this was taken from the Pfizer data. For some reason, it's struggling to come up. Um, I'll just show you the whole thing here so that you can see it. And let's just see if you can see this here. It was looking at the 40,000 cohort here. And let's see if we can get this larger. Yes, from this 40,000 cohort here, when we heard about the 95%, and it was a relative risk reduction, this equated to an absolute risk reduction of 0.9%. And what that meant is that in order to prevent one person in this 40,000 cohort from going into hospital, you'd have to vaccinate 111 people. And this would have been the ratio, the placebo to the vaccinated. So 10 of that group versus 190 of this 400,000 cohort. As the relative reduction changed all the way down to 54%, and they were talking 57%. So I presume they meant relative risk reduction, which is actually 0.51 or about 0.52. So you would have needed to treat 194 people to prevent one admission. And if you were looking at the cohort of 40,000 people, you would have 190 who were not exposed compared to 87 who were already vaccinated. The point I'm making is that within this cohort of placebo, what you would find is as they became more exposed to the virus with natural immunity, their risk would have dropped off significantly. And so, what we are left with is that in the vaccinated cohort, you're finding that about 87 in a 40,000 cohort, which would increase. This is peak efficacy as well. It's not the same in a year. In a year's time, this efficacy may have dropped to zero and they have to boost it again. And it's that kind of situation that therefore makes the numbers of 1.4 million, in my simple mind, not being a statistician, makes no sense. Because if that was the case, I would expect excess mortality to be down, significantly down, 10 to 15% below what the 5 year average would have been between, say, 2015 and 2019. That's not the case. So it raises probably more questions than it gives us answers and reassurance. And I can understand that those people want to reassure the public that they did the right thing. That's understandable. But we are now at a time where trust has been completely decimated. And what is more important is for these leaders in public health to acknowledge what was right, acknowledge what was wrong, and try and see if they can rebuild public trust. I don't think people understand how significant that is. I wish I had the picture to show you what it was that I saw that made me really reflect. They said they had a wine glass in this image, and they said that trust is like glass. Once you break it, even if you try to put it back together, it's never the same again. And I think that this is such an important point. We have to first be honest, acknowledge the mistakes, then start to rebuild trust. That's the only way that we're going to make it out of this because trust has been so decimated. Thank you to all my subscribers who make comments on Substack, on YouTube. It gives me an insight that very few people seem to have because they are not asking the questions. I see what you are thinking, I see what you are feeling, and I get it, I understand it. But I am worried because it has direct impact with regards to what we can do from a scientific and medical point of view to try and help you to be better in the future. So, as usual, I remind you, please continue the journey with me. Join our newsletter. If you're interested in Storm and learning more about Storm, there's a link to the course, which is still discounted at the moment. Please join me for this education. This is a time where education is most important because, as you can see, not many people are going to be honest about what is happening and what is likely to happen in the near future. Have a great evening. Look forward to talking to you again soon.